Next session will be postgraduate course HCC1. This session will be chaired by Dr. Changjin Liu, Dr. Masao Omata. Doctors, please.
Good afternoon, ladies and gentlemen. I'm Cesar from Taipei, Taiwan. Today, this postgraduate course will focus on hepatocellular carcinoma. And we have three very famous speakers from Japan, from Korea, and from Taiwan talking about the clinical biomarker discovery, imaging study, and treatment guideline update regarding the hepatocellular carcinoma. And totally, we have 90 minutes. So after the three talk, we'll have a group discussion. And without any ado, I will introduce the first speaker. The first speaker, Professor Takahiro Kodama, is currently assistant professor, Osaka University Graduate School of Medicine. He received his MD and PhD training in Osaka University, and later also the GI and liver training. And he has published many outstanding papers, so got a lot of outstanding awards, including Okita Award, Early Cancer Investigator Award, ASLD, and also ASCR Scholar and the JSH Award. So today, it is our great pleasure having him talking about the discovery of therapeutic and biomarker for hepatocellular carcinoma through basic and translational research of tumor and microenvironment. Please join me and welcome Professor Kodama.
Thank you, Professor Lee, with a very kind introduction. It is a great honor for me to have the opportunity to present my data here today in this postgraduate program in APASE 2024 in Kyoto. So today I'm mainly talking about the biomarker of the HCC, especially in terms of the immunotherapy efficacy. So next 30 minutes, I would like to try my best to enjoy your audience. So this is the agenda of my talk. So first 10 minutes, I'd like to briefly touch on the current HCC immunotherapy, basics of the cancer immunity and the mode of action and the efficacy of these two combination immunotherapy. And then I move on to the current biomarkers part for HCC immunotherapy, mainly focusing on our research study. So as you know, the advancement of the pharmacotherapy for the unresectable HCC is huge. Within these 6 to 7 years, several good drugs actually became available. And now in Japan, we have the 8 regimens available, especially these 2 combination immunotherapies are really promising. So this is two pivotal clinical trial result of the combination immunotherapy. The left-hand side is the IMbrave 150, showing this atezolizumab and bevacizumab. Atezolizumab shortly shows a significant superiority to the sorafenib in the OS setting. And the right-hand side is the Himalaya study, which is the steroid regimen, which contained durvalumab and tremelimab, durvalumab shortly. This also shows a statistically significant response to the compared to the sorafenib. So based on these 2 combinations immunotherapy, the variety of the clinical guidelines are updated, including the SLD one and also a Japanese one. And now all the guidelines recommended the atezolizumab or durvalumab as a first line, unless there is no contraindication for the ICI therapy. So the most important thing that we are most interested in how we're gonna use these 2 combination immunotherapy nicely, right? So to this end, we need to understand, cancer immunity in HCC. So this is the latest update provided from the Professor Lobet and the Mount Sinai in the Nature Review Clinical Oncology. The left-hand side is the immune cell that protect cancer cells, and also right-hand side is the immune cell that attack cancer cells. As you can appreciate, there are very complex interactions shown here. So that makes us difficult to understand, right? So I always try to focus on the main player of this cancer immunity, which is the cytotoxic T cells located at the center of this cartoon CD8 T cells. And this is a famous cancer immunity cycle. So basically explain how the T cells are educated and recognize cancer cells and kill the cancer cells. So let me briefly remind you this cancer immunity cycle. The first steps, the tumor cells secrete the cancer cell antigen, and this cancer cell antigen is taken up by the antigen presenting cells, such as the dendritic cells, and move to the regional lymph node, and the DC cell present the antigen to the naive T cells, and the T cells get educated and become the CTLs. This process called so-called priming phase. And then after the priming, the CTL move to the blood vessel and then go into the tumor site and recognize the antigen presented by the surface of the cancer cells and they kill the cancer cell by secreting the cytotoxic cytokines or chemokine. Also, this cancer immunity cycle is recently updated, the more focusing on the inside the tumor microenvironment. So even after T cell come into the tumor site, they also have to overcome some of the barriers, such as the stroma barriers, also the immunosuppressive cell interaction, and also the CTL have to maintain the effector state and the function in the tumor microenvironment. But nevertheless, if this cancer immunity cycle work properly, that means the systemic immunity recognize and keep the cancer cells silent, so cancer cell cannot grow. However, this cancer cell also try to cleverly escape by producing a variety of the stimulatory and the inhibitory factors shown here. Then among these variety of the molecules, now we can target 3 molecules, including the CTLA-4 in a priming phase, and also VEGF in a blood vessel phase, and also the anti-PD-L1 for the effector phase. So basically, this 2 combination immunotherapy is a combination of the 2 of the 3. So let me go to the detail of the mode of action of the atezolizumab therapy. So bevacizumab is an anti-VEGF antibody, so basically normalize the tumor vasculature and they improve the hypoxia and also increase the immune cell and drug delivery. And also atezolizumab is an anti-PD-L1 antibody, so blocks the PD-1 and the PD-L1 signaling in the tumor microenvironment, so they invigorate the exhausted T cells. So also, so when we talk about these kind of things, so also anti-VEGF antibody recently have a variety of different functions. So anti-tumor immunosuppressive effect of VEGF, including the inhibition of the DC maturation, and also the M2 macrophage polarization, and also recruitment and activation of MDSC and Treg. So when we block the VEGF signaling, not only this vascular phase, but also the priming phase and the effector phase, it works. So this seems to be this combination immunotherapy actually works a variety of the steps of the cancer immunity cycle. And I think you may hear many times of this kind of story, but you may not see actually what's going on after the treatment. And it is not easy to obtain the sample after the treatment, combination immunotherapy in a human sample. So instead, we try to look at what happens in a mouse model. So this is a novel mouse model that we created, immunocompetent endogenous and rapid HCC mouse model, mimicking the intertumor heterogeneity of the driver genes. So what we did is we cloned 10 HCC oncogene into the sleeping beauty transposon vector together with the molecular barcode and generated the oncogene library, the pool library. And then we introduced this library into the immunocompetent BRAC6 mouse liver through the hydrodynamic therapy injection. So surprisingly, within two weeks, these mice developed 100 of the liver tumors expressing the high level of the AFP and the glipcan-3, and these tumors are diagnosed as HCC by the histology. And more importantly, when we isolate the tumor DNA from these tumors, and then we can do the deep sequencing of the molecular barcode in tumor DNA to determine what kind of the driver genes actually affect in these each tumors. Now, as you can appreciate it, each tumor has a different pattern of the driver gene, indicating these tumors are really intertumor heterogeneous. So this mouse model recapturates the intertumor heterogeneity of the driver genes observed in human setting. So using this mouse model, we treated this animal with the anti-PD-L1 and anti-VEGF antibody. And as you can see here, actually, that after the treatment, CD8 T cells are infiltrated into the tumor site, but not only the CD8 T cell, but also CD4 T cell and also dendritic cells. And this immunocombination immunotherapy suppressed angiogenesis assessed by the CD31 endothelial marker. And also when we look at the CTL activity, interferon gamma and granzyme P and farfolin are elevated, so the CTL are activated. And then in the consequence, mouse live longer. So actually, this combination immunotherapy activated the T cells. Moreover, we isolated the tumor immune cell from this treated mouse, and then we performed the single cell sequencing, and we focus on the CD8 T cells. So overall, CD8 T cells activation marker were elevated by the treatment. And also, we categorize these CD8 T cells into 5 clusters from the naive, memory, TPEX, and TX early, and TX TAM. So basically, the T cells are CTL are differentiated from naive to these exhausted states. So as you can see here, when we treat the animals, the naive T cells are decreased, and instead the early exhausted T cells are increased. This is the effect of CTLs, suggesting this combination immunotherapy activated the CTLs. So next, I move on to the mode of action of the STRIDE, durvalumab and tremelimumab. So durvalumab is anti-PD-L1 antibody, so basically similar to the atezolizumab. And anti-CTLA-4 antibody, the tremelimumab, so works on a priming phase. So once again, what the priming phase do? So as I mentioned before, the dendritic cells express the antigen to the naive T cells, and then T cells get activated and produce effector CTL and also memory CTLs. But during this process, actually antigen presentation is not sufficient to activate T cells. It also requires a co-stimulatory signal between the CD8, CD86, and CD28. But during this process, once CTLA-4 is expressed on a naive T cell on the surface, actually CTLA-4, the affinity to the CD80, CD86 is much, much higher compared to the CD28. So once expressed, the CTLA-4 binds to the CD80 and blocks this co-stimulatory signal. So when we apply the CTLA-4 antibody, we block this signal and fully activate the CDLs. So based on the mode of action of the immunotherapy from the perspective of the cancer immunity cycle, actually they are slightly different. So if we can determine which process is actually impaired in each patient, we may be able to stratify this combination immunotherapy. However, it's not actually easy to understand the impairment of each process. So as a surrogate, we can predict the failure steps of the cancer immune cycle based on the immunotypes of the tumor microenvironment. So immunotypes is classified into 3 groups based on the T cell infiltration. So immune desert, there is no immune T cells. The immune excluded phenotypes, there's T cells only the surrounding tissues, and the inflamed phenotypes is T cells inside the tumors. And basically, these inflamed tumors are considered as immune hot status, and also immune desert and excluded are considered as the immune cold phenotypes. So we performed the RNA and the DNA sequencing of the 113 HCC patient and then analyzed the tumor microenvironment. And as you can see here, the 2/3 of the patient are actually immune cold phenotypes, which may partly explain why the nivolumab and the pembrolizumab, the monotherapy, does not fail in the clinical trial. And in addition to the VEGF antibody or CTLA antibody works better. However, even the combination immunotherapy, when we look at the response, atezolizumab overall response is 30%, and initially 20% are non-responder. And the STRIDE regimen, overall response is 20%, and initially 40% are non-responder. And then when we look at the overall survival stratified by the response, the non-responder has a very poor prognosis. So these data clearly indicated the biomarker to predict the efficacy is highly higher, in order to avoid to use this kind of drug for the patient who may not respond. So the next 20 minutes, I would like to talk about the current biomarkers for the HCC immunotherapy. So this is an overview of the source of the various biomarker candidate for the immunotherapy of the HCC. So I'd like to explain one by one. So first, I would like to focus on the tumor-derived biomarkers and also the ctDNA produced from the tumor cells. So this study analyzed the PD-L1 expression by the immunohistochemistry from the atezolizumab patient cohort of the IMBRAVE 150 trials. And then they stratified the patient based on the positivity of the PD-L1, 1% and 5% and 10%. And as you can see here, 1% or 5%, the PFS is not actually different. Only the patient who has 10% positivity or higher in the PD-L1 expression seems to show better. However, the number of the patients is very few. So that means the clinical utility of this marker is not good. So what about the steroid regimen? So this is a Himalaya trial, the forest plot of the overall survival in the patient subgroups in the steroid and the durvalumab monotherapy. And as you can see here, the PD-L1 positive or negative did not show any difference. So that means in the steroid regimen, PD-L1 expression is useless. So although PD-L1 expression is used as the marker for the selection of the ICI therapy in lung cancer and breast cancer, however, the PD-L1 expression is not useful to predict the efficacy of the combination immunotherapy in HCC. So this is a tumor mutation burden, which related to the cancer neoantigen and related to the sensitivity to the ICI therapy. So this, again, from the IMBRAVE 150 trial, among the 755 patients, only 1% have the TMB high, and the TMB status actually did not affect the overall response rate and also PFS. So TMB is used for the marker for the selection of the pembrolizumab treatment. However, the TMB is also not useful for the predicting the efficacy of the combination immunotherapy in HCC. So what about the tumor genomic mutations? As you know, that the tumor mutation, most frequent mutation in HCC is the TAR promoter and followed by the beta-catenin and p53. And the beta-catenin is known to induce the immune cold phenotypes in a variety of the cancers. So we look at the PFS. Actually, the patient who has the beta-catenin mutation, the atezolizumab seems to be similar to the sorafenib. On the other hand, patient with a beta-catenin wild type, atezolizumab seems to be better. So this data suggested beta-catenin mutation may affect something on the atezolizumab response. However, this data should be interpreted cautiously because when we look at the PFS, actually atezolizumab group, either a mutation or wild type, there's no difference. When we look at the sorafenib, actually mutated groups have the much better PFS, so suggesting some of the bias may exist in this cohort. So indeed, when we look at overall survival, regardless of the beta-catenin mutation or wild type, atezolizumab seems to be better. So this is another study from the Japanese group, also looking at the beta-catenin activation, but not the genomic mutation, but the activation by the immunohistochemistry of the beta-catenin and the GS staining. And although this is a small cohort, the either beta-catenin activated group or non-activated group, the response rate is not different, and also overall survival is not different upon the atezolizumab therapy. And we also tried to analyze the association between the mutation and the therapeutic outcome of the atezolizumab therapy. But in this time, we did not use the tumor tissue. Instead, we used the ctDNA. So we collected the plasma from the 85 HCC patient and performed the next generation sequencing to identify the ctDNA. So this waterfall plot showing the mutation profile, as you can see here, the most frequently mutated genes, the TAR promoter and the p53 and the beta-catenin, which is perfectly similar to the genomic tumor genome mutation profile. So suggesting this data may be reasonable. So we look at the association between the mutation status and the therapeutic outcome. And we found that this beta-catenin mutation does not do anything about the therapeutic outcome. On the other hand, we found that the patient with a TAT mutation has a significantly shorter overall survival. And then later on, we found actually these patients have the poorer liver function, also more advanced liver stage that may affect the overall survival. So next, I would like to move on to the molecular signature of the tumor tissue. So these are the gene expression signature of the tumor tissue to predict the outcome of the ICI therapy. So such as the inflammation signature for the nivolumab, interferon antigen presentation signature for the PD-1 inhibitors, and also atezolizumab response signature for the atezolizumab. These signatures nicely stratify the patient PFS and OS. So try to validate this finding. We also collected 23 HCC tissue before the treatment of the atezolizumab therapy. And we split this responder and non-responder. And as you can see here, responders show the higher levels of interferon gamma and granzyme B and CXCL9, so suggesting the T cell activation, and also higher levels of variety of the HLA expression, and the pathway levels, antigen processing presentation pathway, and the T cell and B cell receptor pathway is actually activated. And also, when we look at the signature, immune signature and the T cell exhaustion signature are highly elevated. So immune hot tumor microenvironment was associated with a response to the atezolizumab therapy. We also checked this reported signature and found the responder has a significant higher ABRS signature than interferon signature, and especially ABR signature nicely stratified the PFS. So next we move on to the time, immune cells in the time. So this is again from the IMREB 150 trial. So they stained the CD8 T cell by the immunohistochemistry and stratified immune hot cell tumors and the immune cold tumors. You can see here the immune hot tumors atezolizumab seems to be better than sorafenib. However, in cold phenotypes, there is no difference. So immune CD8 T cell infiltration should be maybe the prerequisite for to get the response from the atezolizumab therapy. And recently, the technology for the spatial analysis of the tumor microenvironment is investigated, including the DSP and mass cytometry and the BGM spatial transcriptome and spatial proteomics. So we also perform the spatial transcriptomics to analyze the tumor microenvironment. So in this study, we use 8 patients, 4 responders and 4 non-responders, a tumor tissue, and perform the BGM spatial transcriptomics. So this BGM is one spot is 70 micrometers, so contain about 10 cells. So we first collected all the cells and then it put into the UMAP cluster. So you can see that these spots are actually classified into the 8 different clusters represented by the cells inside the cluster, such as the malignant cells and CD14 cells, malignant cells and the immune hot status. And we compare this frequency of these spots between the responder and non-responder. As you can see here, the malignant and immune hot clusters are significantly higher in the responder, so indicating the proximity of the tumor cells and the immune cells are important to get the response to the therapy. And we further dive into this kind of the proximity analysis. So using the K-function method, I'm not going to go to the detail of this method, but the point pattern analysis, basically this shows how these spots are distributed, so cluster or like dispersed. So here's the result. So left panel is the non-responder, the right panel is the responder. As you can see, the responder, the immune hotspot were actually clustered, but in the responder, immune hotspot were actually distributed evenly. So these data, as further suggested, this spatial analysis suggested this the tumor proximity of the tumor cells and the immune cells all over the tissue evenly, which is important for get the response from the atezolizumab therapy. So next, move on to the soluble factors. So in order to identify the soluble factor associated with the treatment response, we again use a mouse model. So this time we treated this mouse with anti-PD-1 and anti-VEGF antibody for a long time to get the resistant tumors. And we collected the tumors, the susceptible tumor and the resistant tumor, and performed the single cell sequence to compare the immune cell profiling. And we found a resistant tumor, actually, that there is no CD8 T cell and CD4 T cells. So tumor resistance to this combination immunotherapy is immune cold phenotypes. And then we checked the sort for the variety of the cytokine and chemokine and found a high IL-6 level in these resistant tumors. At the same time, we also searched the secreting soluble factors by checking the variety of the cytokine and the chemokine from the 65 HCC patient before the initiation of the atezolizumab therapy. We performed a multiplex suspension array, and simultaneously we actually found the IL-6 high IL-6 levels are significantly associated with the risk of the non-responder. So as a validation analysis, we checked the IL-6 levels by the ELISA. And as you can see here, the IL-6 high patient has a significantly poor response and a shorter PFS and OS. Now, after we published this paper, the Korean group also published the same data, and they also showed the tumor microenvironment analysis. They found that the IL-6 high levels showed a significantly lower number of the CD8 T cell infiltration, so indicating high IL-6 cases are immune cold and worse treatment efficacy and the prognosis upon atezolizumab therapy. So next, circulating immune cells. So to this study, we isolated the PBMC from the 5 responder and 5 non-responder of the atezolizumab therapy at the treatment and also on treatment and performed the single cell analysis. So we collected the total 230,000 cells and clustered into 30 clusters, like NKT cells and myeloid cells and the B cells. And we compare the frequency of each cell population between the responder and the non-responder. And we found that actually the frequency of the CD4 positive central memory T cells are significantly higher in a responder. So this CD4 T cell population nicely stratifies the PFS of the atezolizumab therapy. We also look at the CD8 T cell, shown here. And then we categorize the CD8 T cell into the 6 groups and check the activation marker. And then we found actually the cytotoxic T cell, the activation marker was significantly higher in the responder compared to the non-responder. So this data suggested not only the tumor site, but also the systemic immune cells, the memory presence of the CD4 T cell, and also activation of the CD8 cytotoxic T cells are important to get the response from the adalimumab therapy. And we also move on to the gut microbiota. So this is a study of the microbiota and metabolite to the relation to the therapeutic outcomes of anti-PD-1 antibody. So the diversity of the microbiota show that the higher level of the inverse Simpson index and the Shannon index in the responder groups and the anti-PD-1 antibody, suggesting the higher diversity is important for to get the response to the anti-PD-1 antibody. This study also found some of the metabolites, such as the galactic acid and uncaloric acid, is related to the therapeutic outcome. So based on this report, we hypothesized maybe antibiotics usage may be related to the adalimumab response. So we checked the medical record of the 105 HCC patients who underwent adalimumab therapy, and we found actually 90 patients used antibiotics within the 30 days before the adalimumab treatment. And interestingly, this patient with antibiotics treatment significantly poor disease control and also significantly shorter PFS and OS, suggesting antibiotic use may also affect the microbiota and also may affect the response. So lastly, we would like to talk about the imaging study. So in this study, I focus on the steatotic HCC, which is represented by the lipid cell deposition inside the tumor cells. This steatotic HCC actually exists 25% of the total HCC and has a unique characteristic such as high tumor-infiltrated immune cells and also higher T cell exhaustion signature and also elevation of the variety of the immune checkpoint, including the PD-L1. So this steatotic HCC showed immune hot but exhausted microenvironment, so may seems to respond better to the ICI. So in order to identify this steatotic HCC non-invasively, we focus on the MRI, chemical system imaging, which is useful to quantify the lipid deposition levels. So we isolated 30 HCC patients who underwent EOB MRI, and we found actually 7 patients of steatotic HCC shown here. And as you can see here, these patients show significantly better PFS and also disease control rate, suggesting this MRI can be the imaging biomarker to predict the efficacy of the adalimumab response. So this is a summary of my talk, the immunotherapy biomarkers and the future perspective. So today I showed a variety of the biomarkers from the tissue biopsy and also blood sample on imaging and medical record. Of course, in the near future, it is important to prospectively evaluate this finding, but moreover, because single biomarker's usefulness is limited, so it is important to integrate this biomarker to further accurately diagnose, predict the efficacy using the artificial intelligence, which may also lead to the extension of the patient survival. With that, I'd like to stop here and I'd like to thank you for my colleague and the collaborator, and thank you for your attention, and I'm happy to take any question.
No, panel discussion. Oh, okay, yeah. So we may have some QA from the floor for this presentation. Any question from the floor? So Professor Kotam, facing so heterogeneity of tumor microenvironment, so and also so different combination of the current therapy, systemic therapy for hepatocellular carcinoma. On your opinion, which one is the most promising for clinical application regarding the biomarkers?
Okay, thank you for your question. So I think when I perform the spatial transcriptomics, even the bulk RNA sequence, we can determine, especially in adalimumab treatment, the pre-existence of the T cells, especially the CTLs, are very important to get a response. And then when we further dive into the spatial analysis, we further found not only the number of the T cell, but also the distribution is also important. So if we can collect the tissue for every patient, and then we can look at the detail of the distribution of the CTL, maybe this best stratify the patient, I don't know, patient efficacy. However, in a clinical setting, we rarely, do the biopsy for the patient who especially going to the systemic therapy. And then as I showed today, even the PBMC, we can also stratify the patient based on the CD4 and the CD8 T cell in a systemic immune system. So I think in a clinical real setting, I think the PBMC, the CD4 and CD8 T cell distribution in a systemic immune system is more like useful maybe but I think the accuracy is less. So I think better combine.
I'm in the position that oversee all the malignancy, not just the hepatocellular carcinoma, and at the current situation that unfortunately there is no single marker done better than the PD-1, PD-L1 staining. So if you pick the one or maybe two from this study, I mean comprehensive, overwhelming studies, how do you do that? How do you try to change a clinical practice?
Yeah,
in real sense.
I completely agree. And also non-invasive liquid biopsy is very easy to do, but because in this case actually this not only reflect the HCC tumor but also systemic immune status, so maybe affected by a lot of the factors. So if possible, tumor site and also the systemic immune status, both information is very, very important too, and then maybe further accurately diagnose or predict the efficacy of the treatment response.
Among your so much of studies, the spatial analysis, especially the scattering things, the biopsy specimen you show, that's so impressive. So instead of doing the very expensive ways, just try to pick the one or two markers, like and doing the staining. And it can be used for the clinical purposes. How do you think? The spatial ones, it's very impressive.
Yeah, I think this spatial one actually mainly focus on the CD8 T cell. So as you mentioned, even the simple maybe CD8 and also some of the activation markers, the dual staining, I think that's enough to, when we look at the distribution, I think.
But the problem is, if you take like a pancreatic cancer, basically there is no lymphocytes around the tumor cells. So that may distract the way you try to apply. How do you think about that? I mean, the basic histopathology showing not much of the lymphocyte anyway, like a pancreatic cancers. So in those situations, you have to adjust.
Yes, and also the needle biopsy problem is the sample is too small. So when we did this kind of analysis, actually some of the biopsy samples are fluctuated. Then it's very difficult to accurately count the number of the T cell infiltration. So maybe this biopsy technique is also has to be improved somehow.
People try to look for the one which is good for the patients, giving the advantages. But if you can show there is some marker showing definitely disadvantage for the patients, that may help too, may change the clinical practice. Yes. And in fact, like if you go to the OBGY, uterine cancers, no marker at all, just give it to the patients. But can be very dangerous if there is a marker to say that this is not good for the patients.
Yes, but in the HCC case, at least we have the two combination immunotherapy. So if we can stratify, even if not responding to atezolizumab therapy, if they respond to the STRIDE regimen, maybe it's better too. So, but the problem is so far, all the markers that I show is.
But if you take a look at the STRIDE, Kaplan-Meier is a very touchy one, You got to be careful about that.
Yeah, that's true.
Okay, since time limit, this talk will be crossed. And thanks to Professor Kodama again for your excellent presentation. So let's move to the second talk. The second talk will be delivered by Dr. So-Young Kim from Seoul. Professor Kim is currently a professor, Department of Radiology, Division of Abdominal Imaging, University of Assam College of Medicine, Assam Medical Center. She also graduated from the St. College of Medicine. She has devoted his career to imaging of HCC using various modalities. So currently, he has many outstanding publications in this field. So today, we are very pleased having her talking about the cutting-edge image of HCC. Professor Kim, please.
Thank you for your kind introduction, Professor Liu. It's my great honor and pleasure to have the opportunity to give a talk here in this privileged meeting. Today, I will talk about cutting-edge imaging for HCC. Here's my disclosure. The role of imaging in HCC is distinctive, offering non-invasive diagnostic capabilities unparalleled in many other solid tumors. There have been lots of changes in HCC guidelines during recent several years. Let's look at the important milestones of HCC guidelines. I know this slide looks very busy. However, it reflects ceaseless changes in the guidelines for HCC. Since ISO first proposed the first guidelines in 2001, over the past 2 decades, lots of organizations and societies from Korea, Japan, Asia, the United States have published the imaging-based criteria for HCC. In 2007 and 2018, the guidelines across the globe have been revised. Recent updates of major HCC guidelines, including those established by APASO, have underscored the pivotal role of magnetic resonance imaging employing hepatobiliary agents and contrast ultrasound in the diagnosis and management of HCC. All of you must be familiar with the X, which is a widely used MRI contrast agent for liver imaging, as it has a unique property as a hepatocyte-specific MRI contrast agent. With a lipophilic modification of GET-TTPA, this contrast is taken up by hepatocytes through this anion transporter called OATP1B3. Immediately after the injection, X acts like an ordinary extracellular contrast agent, which provides us hemodynamic information. After several minutes later, however, this contrast starts to be taken up by hepatocytes and present wonderful hepatobiliary phase imaging in 20 minutes after contrast injection, giving us tissue-specific information as well as a very high CNR for high CNR imaging for hepatic lesions. It seems like killing 2 birds with 1 stone. One of the most prominent changes, the revision of all these guidelines, is the active adoption of EOB MRI as a first-line imaging modality. The superb diagnostic performance of EOB MRI has been proven by recent meta-analysis. It's one of the major changes in the Western guidelines from AASLD and ISO in 2018, while Asian guidelines, including the Korean guidelines, have embraced EOB MRI as a first-line imaging modality. This is the previous version. However, in terms of interpretation of imaging features in EOB MRI, there are some differences. Here is a case of a 65-year-old man with chronic B-related liver cirrhosis. We can see a nodule here in hepatic segment 5, measuring 1.1 centimeters in diameter. On T2-weighted imaging and diffusion-weighted imaging, the lesion has mild to moderate high signal intensity. We cannot find presence of fat in this tumor. On dynamic studies, the lesion shows arterial phase hyperenhancement. We cannot see any washout during the provenous phase and transitional phase, while the lesion looks hyperintense on hepatobiliary phase imaging. So do you think we can make a definite diagnosis for HCC in this case? In fact, depending on the diagnostic criteria, the answers are different. Let's start with the EASL criteria, which proposes the simplest diagnostic approach. According to these guidelines, only arterial phase and portal venous phase can be considered as we make a diagnosis of HCC on EOB MRI. The radiologic hallmark of EOB MRI are defined as the AP and washout only in portal venous phase. So we cannot make a diagnosis of HCC for this case. I suppose it's somewhat ridiculous not to consider information from the other sequences. In fact, what's the point of in performing EOB MRI if we are not allowed to utilize all information? Let's move on to the AASLD guidelines. The AASLD guidelines also define washout in EOB MRI only in poor venous phase. Transitional phase hyperintensity is merely regarded as ancillary imaging features favoring malignancy. As this nodule does not fulfill the major diagnostic criteria, we cannot call it as a definite HCC according to the AASLD guidelines. However, this nodule considered as probable HCC due to the presence of ancillary imaging features suggestive of malignancy. How things are going to change in the Asian guidelines. Different from the previous Western guidelines, the Korean guidelines generously extend washout to the transitional phase and hepatobiliary phase. Thus, this nodule can be diagnosed as HCC as a definite HCC, as it has the major imaging features on EOB MRI. In fact, the lesion was confirmed pathologically as HCC. As you've seen in the previous slides, the timing of determining washout appearance in EOB MRI is one of the major differences among the guidelines. The reason why the Western guidelines stick to confine the timing only during the poor venous phase is the fear for losing the specificity in the diagnosis of HCC. Why do all the different imaging systems exist? It can be explained by the fact each system should address different target population, medical resources, and treatment practices. For example, Korea is one of the highest HCC prevalent countries. MRI is available at an affordable cost due to the National Health Insurance Program. The mainstay of treatment for HCC in Asia, as well as in in Korea, as well as in Asian countries, is hepatic resection or RF ablation, rather than deceased donor liver transplantation compared to Western countries. Thus, sensitive diagnosis of HCC is very important than specific diagnosis, which is quite different from the Western world. Hence, the imaging method and diagnosis system for HCC vary according to the different geographic areas. I believe the majority of you have read this paper by Dr. Ju from Seoul National University Hospital, Seoul, Korea. This study published in 2015 warned the specificity would be decreased to less than 50% if we encompassed hyperintensity during transitional phase and hepatobiliary phase as washout. However, if you take a closer look on this data, we can see the majority of false positives are cholangiocarcinomas and hemangiomas, which can be easily diagnosed on ancillary imaging features. Interestingly enough, the same authors published a follow-up study recently demonstrating that the specificity can be raised up to 87% by including exclusion criteria like this. Thus, after excluding hemangiomas and cholangiocarcinomas, encompassing hyperintensity during the transitional phase or hepatobiliary phase imaging as washout increases the sensitivity while maintaining the specificity. This is the reason why the latest Korean guidelines specify the exclusion criteria. I suppose hepatobiliary phase imaging, hepatobiliary hyperintensity should be considered as a major feature when EOB MRI used as a contrast agent. Exclusion criteria for common false positives such as hemangiomas or cholangiocarcinomas are required to maintain specificity. Although we've discussed sensitivities and specificities so far, I suppose that the performance of diagnostic tests for HCC should be eventually evaluated by the improvement of clinical outcomes, including survival gain or reduced mortality. This study from Samsung Medical Center in Korea analyzed more than 3,000 patients with HCC using a national database to evaluate the clinical impact of mortality by the use of EOB MRI. This study found that adding EOB MRI to CT was associated with lower mortality compared to extracellular contrast agent MRI, especially for localized disease. Here is a summary of differences of the major guidelines of HCC. The Asian guidelines differ from the Western guidelines when it comes to timing of washout. The EASL guidelines do not specify the use of exclusion criteria, while the other guidelines clearly declare the exclusion criteria to main specificity. Now, I would like to change the gear a bit here by addressing HCC surveillance. Let's start with a review of current guidelines regarding HCC surveillance. As you all know well, the target population is a high-risk patients with chronic viral hepatitis or liver cirrhosis. All the HCC guidelines across the world recommend ultrasound with or without alpha-fetoprotein every 6 months in this patient as a major surveillance tool. According to a recent meta-analysis, including 15 studies, the sensitivity of ultrasound for detecting early HCC was 47%. Do you really think it's good enough, although the number is roughly similar to the probability of flipping coins? To make it worse, the target lesion in the previous meta-analysis is early HCC, according to the BCLC stage system. However, the target lesion for surveillance, particularly the non-transplant setting in most Asian countries, are in fact smaller ones, specifically smaller than 2 centimeters, as known as very early stage HCC. I would like to share results from 2 prospective studies from Korea, which evaluated diagnostic performance of ultrasound, particularly for very early or early stage HCC. The first study is the PRIO study, which was performed in my institution, and second one was from Seoul National University Hospital, Seoul, Korea. Here is the results of the PRIO study. In 43 patients with HCC, 75 of them were stage 0 HCC. The mean size of 48 HCCs were 1.6 centimeters. The sensitivity of ultrasound in this study was very disappointing, as it was less than 30%, while complete liver MRI showed 86% of sensitivity. This difference held true for stage 0 HCC. The second study from Seoul National University, this study design was almost identical to the previous study. 139 patients with annual risk of HCC more than 5% were included. As you can see here, the size of HCC in this study was also similar to the previous study. Among 24 patients, 17 of them were very early stage HCC. The sensitivity was less than 30% for all HCCs and only 70.7% for a very early stage HCC, which was even worse than the results from the previous study. Thus, these 2 studies suggested that the diagnostic sensitivity of ultrasound for very early or early stage HCC is disappointing. I suppose these disappointing results of ultrasound can be attributed to the visualization issue. In our daily clinical practice, we frequently encounter patients with a poor Sony window like this. Through subcostal and intercostal approaches, the liver cannot be sufficiently evaluated as the liver is shrunken due to liver cirrhosis. The LILAD suggests ultrasound visualization score system. It classifies the degree of liver visualization into the 3 categories. So can you guess how frequently encounter insufficient ultrasound scored as C? From the pre-study data, almost 30% of ultrasound regarded as score C. It's quite mind-boggling, isn't it? In this patient, is it okay to stick to ultrasound as a surveillance tool, even though it looks like any targets without seeing it? Let's get back to the guidelines for HCC once again. Previous version of HCC guidelines from the world described ultrasound as a sole imaging modality for HCC surveillance. Recently, however, evidences regarding the limited performance of ultrasound in HCCs culminate some interesting changes in the major HCC guidelines, which were revised in 2018. All the major 3 guidelines around the world allow the use of alternative surveillance tools such as CT or MRI in selected patients with inadequate ultrasound. Alternative strategies other than ultrasound include contrast-enhanced ultrasound, contrast-enhanced CT, complete MRI, and abbreviated MRI. Here is a summary of pros and cons of alternative surveillance tools. Contrast-enhanced ultrasound still has only limited data regarding its diagnostic performance, and it cannot overcome the limitation of poor Sony window. As for contrast CT, in spite of its excellent diagnostic performance, radiation and contrast hazard cannot be ignored given the repetitive nature of surveillance tests. In spite of its superb diagnostic performance of complete liver MRI, long examination and interpretation time, as well as high costs, are obstacles to adopt complete MRI as a main surveillance tool. Thus, abbreviated MRI looks like a very reasonable option. You may not be familiar with the concept of abbreviated MRI. In order to understand abbreviated MRI, we'd better start with the protocol of complete MRI. This is complete liver MRI protocol commonly used for evaluating focal hepatic lesions. It consists of multiple sequences, as you can see here. Among these sequences, in and opposed phase imaging, T2-weighted imaging, and dynamic phases are for characterization of focal hepatic lesions, while diffusion-weighted imaging and hepatobiliary phase imaging are commonly used for detecting lesions. Complete MRI with contrast agent commonly takes more than 30 to 40 minutes. However, on abbreviated MRI, sequences are simplified as possible to reduce time and cost while maintaining the diagnostic performance. As you can see here, abbreviated MRI is commonly composed of 2 or 3 key sequences for detecting and characterization of lesions. Abbreviated MRI can be classified according to the use of contrast agent. With the contrast agent, we can choose hepatobiliary agent or extracellular contrast agent. Non-enhanced abbreviated MRI with a contrast agent can be also performed. By including the 2 most sensitive sequences like hepatobiliary phase imaging and diffusion-weighted imaging, hepatobiliary agent abbreviated MRI shows the highest sensitivity among the abbreviated MRI approaches. As you can see here, there are 2 lesions showing hyperintensity on hepatobiliary phase imaging. The larger lesion is considered as positive finding as it shows diffusion restriction as well as moderate hypersignal intensity on T2-weighted imaging. The smaller one is considered as a cyst as it has bright signal intensity on T2-weighted imaging. Hepatobiliary agent abbreviated MRI is the area of very active research among abbreviated MRI protocols. The sensitivity was more than 80% and specificity was more than 90%. All of them are, however, retrospective studies and the sensitivity could have been overestimated. In addition, there are some issues in hepatobiliary agent abbreviated MRI. Additional record tests, including dynamic information, are required if positive finding is detected in order to make a diagnosis of HCC. Hepatobiliary phase imaging quality influenced by liver function can affect the lesion conspicuity. In addition, vascular thrombosis can be missed. There can be potential harms related to contrast agent, which will be discussed later. Now let's move on to the extracellular contrast media MLA. This protocol can be obtained using extracellular contrast agent with dynamic sequences only just like CT scan. A total scan time will be less than 10 minutes. All the sequences are used for both detection and characterization. The major advantage of this strategy is that it can demonstrate the major imaging features essential for a definite diagnosis for HCC. If the lesion fulfills the major criteria of HCC by showing AP and washout during the poor venous phase or delayed phase, just like this study, an HCC diagnosis can be made just based on extracellular contrast abbreviated MRI alone without the need for further confirmative tests. Another advantage is the vascular thrombosis can be detected and evaluated on extracellular contrast MLA. However, ancillary MRI imaging features to help diagnosis of focal hepatic lesions cannot be assessed. Contrast-related issues also exist. The diagnosis performance of this approach has not been well studied yet. This study published last year in Radiology included 161 patients with early stage HCC and 133 patients without HCC. However, I suppose this study showed the sensitivity of 88% and specificity of 89%. However, I suppose the result of this study cannot be directly applied to our surveillance setting as the more than half of the cases patients had HCC, which are not typical for a surveillance setting. Of late, many studies warn that get accumulation in tissue after repeated doses of MRI contrast agent. Thus, European Medicines Agency has banned the use of majority of linear contrast agent. Though linear, EOB is allowed to be used owing to its unique diagnostic roles. We need to beware, however, the potential harms of GAD-based MRI contrast agent, including body accumulation and nephrogenic system fibrosis, although they are relatively safer than iodine CT contrast agent. In this regard, non-contrast MRI looks very attractive as a surveillance test, as there is no need for contrast injection, which eliminates contrast-related issues as well as saves cost and time. We can detect lesions based on diffusion-weighted imaging and characterize lesions on T2-weighted imaging. Here is an example of a positive case of non-enhanced MRI. If the lesion is detected like this, additional recall tests, including dynamic information, are needed. In this approach, diffusion-weighted imaging plays a very important role to detect lesions, but sometimes the image quality of diffusion-weighted imaging can be unsatisfactory as diffusion-weighted imaging is prone to many artifacts. Vascular thrombosis can be missed as well. The sensitivity of non-enhanced MRI is lower than is around 80%, which is a bit lower than contrast-enhanced approaches. While there are a wide range of values, the specificity is very high as it was more than 95%. Here's a summary of abbreviated MRI protocols. Emily approaches can be a hepatobiliary agent abbreviated MRI, extracellular contrast abbreviated MRI, and non-enhanced abbreviated MRI. We need to really careful to see the results of previous studies regarding abbreviated MRI, as the majority of these studies are retrospective or non-randomized trial or not from a real surveillance setting. There are several ongoing ICT comparing abbreviated MRI techniques and ultrasound, which will reveal the true diagnostic performance of abbreviated MRI in a surveillance setting. Who are the candidates for abbreviated MRI rather than ultrasound? When we apply expensive approaches such as MRI and surveillance tool, cost effectiveness should be considered. As previous study demonstrated, the instance of HCC is the main determinant of the cost effectiveness of HCC surveillance. Thus, this study compared the ultrasound approaches and MRI-based approaches according to HCC risks. Risk stratified surveillance strategy targeting high and intermediate high-risk patients using MRIs are cost-effective and outperform the non-stratified annual approaches using annual ultrasound as recommended in the current guidelines. As I told in previously in my talk, patients with poor ultrasound visualization like this can be candidates for abbreviated MRI rather than ultrasound. From a recent study performed in Seoul National University, patients with suboptimal quality of ultrasound have ironically higher rates of HCC development. Thus, patients with suboptimal ultrasound image quality are candidates for abbreviated MRI surveillance. I'm pleased to introduce a recent review article for abbreviated MRI published in Korean Journal of Radiology written by my group. If you are interested in applying abbreviated MRI, I believe this study will be helpful. Let's move on to the prognosis prediction for HCC. HCC is a biologically heterogeneous tumor with varying aggressiveness and risk of recurrence or metastasis. While certain histology and molecular features are known to be associated with tumor aggressiveness and prognosis, this information can be only obtained by liver biopsy or surgery. Given the current practice based on image-based diagnosis of HCC, radiologic prognostic findings likely have clinical implications. There are increasing evidences suggesting the radiologic phenotype of HCC reflect histologic and molecular features, ultimately representing the tumor biology of HCC. Currently, the concept of proliferative and non-proliferative HCC has gained attention. Proliferative HCCs are characterized by chromosomal instability and are associated with high alpha-fetoprotein and poor prognosis. Histologically, progenitor HCC, squamous HCC, and MTM HCC fall into this category. Radiologically, RIM-AP, targetoid or LRM features, very low signal intensity on hepatobiliary phase, and infiltrative growth pattern may suggest proliferative HCCs, and this type of tumor frequently accompanies with microvascular invasion MRI features. On the other hand, high signal intensity during the foraminous phase and intravascular fat component suggest non-proliferative tumors and favorable prognosis. Next, I would like to briefly discuss radiomics for the evaluation of HCC. Unlike classic imaging analysis, which is performed by visual assessment, in a qualitative way, radiomics analysis images using multiple image-derived qualitative features. Radiomic features include shape features, histogram features, texture features, and high-order features. Machine learning methods are mainly used to build a model that processes numerous radiomics features to perform a given task. Radiomics has been applied to oncology imaging as a method for personalized medicine. This approach is based on hypothesis that tumor phenotype may reflect tumor biology behavior. Radiomics may have an effective method for tumor phenotype assessment as it allows for comprehensive and objective analysis on imaging-derived characteristics. There have been a number of studies on the use of radiomics in HCC. This table summarizes some representative studies, and these published studies evaluate the potential value of radiomics in the prediction of microvascular invasion, prediction of recurrence or metastasis after surgery or RF population. I explained the potentials of radiomics so far. However, there are also hurdles that limit clinical utilization of radiomics. Radiomic analysis is a labor-intensive and time-consuming process since it involves multiple steps such as segmentations and feature extraction. Additionally, there have been concerns about the reproducibility of radiomics models as radiomics features are highly dependent on imaging techniques, leading to intersite variability of radiomics features. Here is a summary. The survival benefit of EOB MRI over extracellular contrast agent in patients with localized HCC were demonstrated in a large-scale cohort study and were attributed to the better sensitivity of EOB MRI. Appropriate diagnostic criteria should be applied according to the choice of MRI contrast agent to maximize the unique advantage of each contrast agent. When EOB is used, appropriate diagnostic criteria should be focused on boosting sensitivity with an acceptable loss of specificity. For surveillance, instead of one-side peaceful approaches with biannual ultrasound surveillance, regardless of risks of individual patients, the result of recent studies support a risk-stratified approach with advanced imaging modalities such as abbreviated MRI. Abbreviated MRI should be considered when annual HCC risk is high and when the quality of ultrasound is suboptimal. EOB MRI EOB-enhanced MRI is a powerful imaging biomarker for prognosis prediction. Thank you for your kind attention.
Thank you, Professor Kim, for your excellent review and talk. We have about 2 minutes for discussion. Any question from the floor? So Professor Kim, yeah. So the non-constant abbreviated MRI scenes are promising. So when can we apply this technique in clinical practice?
Yeah, thank you for your excellent question. I agree with your opinion regarding the clinical implications of non-enhanced abbreviated MRI. We've studied, there is an ongoing study comparing non-enhanced MRI and contrast in CT after 2 years after surgery or RF population. So we found that non-contrast MRI is better than even contrast scan, as it can detect very small lesions based on diffuser-weighted imaging. And I believe that patient without any treatment, abbreviated MRI, particularly non-enhanced MRI, is very useful for patients with very high risk for HCC or with a suboptimal ultrasound window.
And it is frequent to have a chronic kidney disease, renal impairment in patients with a hepatocellular carcinoma. In that case, which modality will you consider recommend?
That is a very excellent point. I think in that case, non-enhanced abbreviated MRI is very helpful to detect small lesions for very high-risk patients.
Okay, thank you.
I'm very happy about the very first part of the presentation, comparison of societies differences, especially you like APASL and then the Korean guidelines about that, because people blaming that that guideline APASL is too old, but that particular part is okay, right?
Yeah, right.
Appreciate that. And in reality, actually, you are having the very good clinicians in your department or in your universities. So when we see the patients, not just imaging, but we see the tumor markers, especially people only talk about the AFP, but for a long time I said, why don't you do the lectin binding protein L3? Because that's very sensitive, especially if you ask like every 3 months, every 4 months. Sometimes there is a slight but a steady elevation L3 precede elevation of AFP. That's very catchy for me. In other words, if you think about the patients, of course, we rely on the radiologist, but we have to rely on myself.
Yeah, right, exactly.
So when you compare those three markers, DCP, L3 binding proteins, and the AFP, so what's about this sensitivity and specificity of your abbreviated or EOB MRI?
Yeah, thank you for your excellent suggestion and question. I did not record the exact result, but in my institution, we performed same kind of similar studies to compare very different many tumor markers. Combination of many tumor markers with abbreviated MRI and abbreviated MRI alone. And I suppose that combination of tumor markers will increase the sensitivity of abbreviated MRI.
Because when sometimes radiologists cannot say which is, definitely, then I can decide by myself, just showing the study. Then in addition, we send it to the laparoscopic surgery, it's going down. So
Right.
sometimes you may have a problem, but we can answer the questions. Yes,
That's
that's the situation for my 53 years clinical outcomes. Yes, thank you.
Okay, thank you, Professor Kim, for your excellent talk again. So let's move to the last talk of this session. The last talk of the session will be delivered by Professor Yixiang Huang. Professor Yixiang Huang, a graduate from National Yanmin University. He's currently a full professor of the National Yanmin University. He's also the staff of the Taipei Veteran General Hospital. He's currently the president of Taiwan Liver Cancer Association. And he had done lots of study on Hep B, hepatitis delta, and also recently hepatocellular carcinoma. He has published many outstanding papers. So today it is our pleasure having Professor Huang talking about the updated treatment guideline for hepatocellular carcinoma. Professor Huang, please.
Thank you, Professor Liu, for your kind introduction. So first of all, I would like to thank the organizing committee for inviting me for deliver this lecture. So my topic today is a treatment guideline update, especially focusing on the clinical treatment aspect. So this is my disclosure. So as we know, the HCC is still the main cancer-related cancer deaths worldwide. Regarding the HCC treatment, I think as Professor Omata said, the APASO guideline is quite old, but I think tomorrow will be a new one. So in Asia, I think we always thinking about researchability. So we are focusing on the presence of extrahepatic spreading or the liver function reserve, and also focusing on the tumor number. So if the patient are resectable, in Asia, we always propose the surgical resection for those kind of patients. And if not resectable, then we will consider local regional treatment, and further, we will consider the systemic treatment. And regarding the worldwide, I think the BCLC guideline is widely accepted, including the ESO and the ASLD. For those kind of patient with a very early stage or early stage, then the patient should receive the curative treatment, including the surgical resection or local operation. And in such a consideration, however, we still find a lot of patients will experience tumor recurrence even after curative surgical resection or even by the radiofrequency ablation. In general, there are around 60 to 80% of patients who experience a tumor recurrence after the surgery or the radiofrequency ablation. So in charting the risk about the recurrence, in our previous study showed that viral matter may play a role in the late tumor recurrence. As we compare the baseline HBV HCC patient with a high or low HBV viral load, there was no difference in the recurrence rate in the first 2 years. However, after 2 years of the observation, for patients with a high HBV viral load at the baseline, they will have a higher risk of recurrence after the 2 years. And recently, we know that the AMBRE 050, the adjuvant study, has made its primary endpoint to reduce the recurrence-free survival by using the adjuvant atezolizumab. So in this study, we show that regarding the progression-free survival at the first year, there will be reduced from the about 30% of the risk. However, if you look longer, the progression-free survival, the two TM line made together. So we should observe this longer data to see the really clinical benefit for those kind of patients. And if we look at the study design regarding the high-risk tumor who should receive the adjuvant treatment, the definition is quite diverse, including the larger tumor over than 5 centimeters, multiple tumor more than 4, or with the presence of the vascular invasion or poor tumor differentiation. And however, for the ablation, the definition was rather restrict, including the single tumor 2 to 5 centimeters or the multiple tumor lower than 4. So by using the clinical and the radionomic models, we recently defined AI-based model to predict the outcome of the HCC after the surgical resection. We find that in patients with high risk factor, including the clinical feature or the radiomic feature, we can define the patient who had a high risk for HCC. And we also use the previous, the AMBRE 050 patient definition to retrospectively look at our patient pool. We found that even in patients below to the low risk tumor, they still have a high risk of a recurrence. However, in still significant portion of patients belong to high risk tumor, but they still did not make tumor recurrence. However, by using our AI and the AI-based model, by including the clinical and the radiomic model, we can further define those kind of patients. So in the future, maybe we can select patients by using the evolution learning model to select which kind of patient should receive the adjuvant treatment after the surgical resection. And for the intermediate stage HCC, as you know, this is quite heterogeneous population. So in the past, we only use the test for those kind of patients. However, since the Apple consensus 2019 and 2020, we defined the term so-called test and suitability. It's based on the tumor morphology, such as confirmed tumor, infiltrated type tumor, or the tumor burden, including the 2-7 out. And recently, we find that the BCLC guideline also divide such kind of patient from the intermediate stage HCC. For patients with diffuse, infiltrated, or extensive bilobar involvement are not recommended to receive the test, and those patients should receive systemic therapy instead. And recently, we further defined the tumor burden for the intermediate stage HCC by using the 7-11 criteria. Within 7, we define as a low tumor burden, between 7-11 intermediate stage, and for up to 11 out is high tumor burden. So by using the 7-11 criteria, we can further define which patient we can respond to the case treatment. For patient with a low tumor burden, very high response rate, and the intermediate in the middle, and the high tumor burden, very low tumor response rate. And also, this response rate can reflect on the progression-free survival and the median overall survival. In general, we find that the patient with 11 out, those patients' median survival was only less than 1 year. So those kind of patients should receive systemic therapy. But for patients between 7-11, the median survival still around 22 months. So it's on the average for the intermediate stage HCC. So patient with tumor burden in the intermediate stage, so they should status, the TSC still can be considered. So apart from the tumor burden, and recently we found like the radiologic pattern can further determine the outcome of a first and the subsequent test. We look at our patient cohort in intermediate stage for over 570 patients. And we define the patient into the encapsulated type or extranodal growth or massive type or infiltrated type HCC. And then we found like the tumor response rate for the first test and the subsequent test were highly correlated with the tumor morphology. For patients with encapsulated, they had a very high tumor response for the first time and even for the second time. For the patient with a poor radiology pattern, they had a very poor response rate and also very poor for first test and also for the subsequent test. And this response rate also can reflect on the overall survival. So in general, we find that the patient with confirmed tumor or infiltrated type HCC, those patients had a very poor outcome against the test. And again, we found that the tumor morphology is highly correlated with the tumor burden. For patients with confirmed tumor or infiltrated tumor, those cases will belong to the 211 out status. So in recent, the Taiwan Liver Cancer Association make an update guideline regarding for the intermediate stage and the advanced stage HCC. In such a scenario, we consider the patient with diffuse or the infiltrated, so-called unfavorable radiology pattern should receive the systemic therapy instead of the TACE. And for the intermediate stage HCC, currently, I think a new player is the immunotherapy. So this study is EMERALD-1. It shows that the TACE combined with the immunotherapy, including the durvalumab plus the bevacizumab, also met its primary endpoint of a progression-free survival. So in this study design, they include patients who were inoperable for the HCC. So they include a part of patient within the BCLC A status and extended to the some patient with the BCLC C. Just if the patient did not have a VP3 or VP4 tumor invasion. So this is a wide range of patients who may receive the TACE plus the immunotherapy. And the primary outcome is the progression-free survival. It shows that using the RECIST-1 version 1.1, they find that the progression-free survival for the TACE plus the durva and the beva, the median progression-free survival can be as long as 15 months. However, a longer overall survival should be waited. And regarding from the IO combination with the TACE, in the past years, we also heard from the Professor Couteau that the ABC conversion may be also an option. For some kind of patient in intermediate stage HCC, we can combine the atezolizumab, including the local regional treatment, including the TKI such as the lenvatinib. We can make significant portion of patient may achieve the cancer-free status. And in this data also show 23% of patient can achieve it not only cancer-free, can also drug-free status. However, for ABC conversion, it's not easy for patients with a high tumor burden. So it would be considered for patients within 7, within 11 status that would consider by using the ABC conversion. So, and apart from the immunotherapy, I think in the past, we also combine with the TKI. However, in the past years, the phase 3 study regarding the TKI plus the TACE all failed, except the TACTIS study. This TACTIS study also select patient, I think it's within 11, because the viable tumor number should be less than 10, and the tumor size should be also less than 10 centimeter. By using this criteria, you will see the patient combined with the sorafenib plus the TACE has a significantly longer progression-free survival as compared with the TACE alone. However, the definition of the progression-free survival in this study is untestable progression. So it's different from we call the progression-free survival defined by the RECIST 1.1, as I mentioned in the previous EMERALD-1 study. However, the overall survival by using the TKI plus the TACE looks similar between the two arms. And a very similar design is by changing the TKI into the Devatini. This is a single arms design by using the LEN TACE, and also showed a very high overall objective response rate as high as 80%. And in general, the patient progression-free survival 28 months. So in patients who may have intermediate to high tumor burden, TACE plus the TKI may also be an option. So for intermediate stage HCC, right now the treatment options are diverse, including we can choose patient with taceable, then again we can plus the TKI or plus the IO. For patient with very high tumor burden, then we should select the systemic therapy directly. And according to the recent EMERALD-1 study, all kinds of patients in intermediate stage may consider combined with the local regional treatment by TACE plus the durvalumab plus benzimab if the patients are still taceable. So now I will move to the advanced stage HCC. As you know, currently the immunotherapy is the standard of care for the advanced stage HCC, including the atezolizumab plus bevacizumab or the STRIDE regimen. And most recently, I think just 1 week ago, the BMS company has announced the CheckMate 9DW has met its primary endpoint regarding the overall survival by using the dual IO, the ipilimumab plus the nivolumab. So I believe that in the near future, the first-line treatment will be a little bit changed. Apart from the TKI, sorafenib, atezo, beva, and the STRIDE regimen, and I think in near future, ipilimumab will be another option. And for the second line, I think the different mode of action will be considered. If we first line choose the TKI, I think the second line would be the IO first. But right now, I think the first standard of care for the first line systemic therapy would be the IO based. So I think the second line will choose the TKI. So I think the UMBRELLA 150 and the STRIDE the data has been reported previously. So I will look at the second line treatment. According to the ASOD practice guideline just announced in the December 2023, they suggest that if a patient have a risk of GI bleeding, then the first line we will consider STRIDE regimen. And if a patient are contraindicated for the IO, and we could still choose the sorafenib or lenvatinib. And following that, the first line IO, the ASOD advised sorafenib or lenvatinib can be a preferred agent after the first line IO. And due to the advance in the whole genome sequencing and the whole exome sequencing, I think this is one recent report on the journal hepatology and find that in patients with HCC or combined HCC or cholangiocarcinoma, they find that by using the whole genome sequencing, they still can find the significant portion of patients still can be some druggable alteration. So such a genomic alteration may have some clinical benefit for around 20 to 25% of patients after the second line or third line systemic therapy. So ladies and gentlemen, it's my conclusion. The treatment of HCC depends on the tumor stage and the liver reserve. And currently, the goal of treatment for early stage HCC is to for curative resection operation. However, there is still high risk of recurrence, and we should select such a patient to receive the adjuvant treatment. And for the intermediate stage HCC, there is a quite heterogeneous nature, and the outcome of test is varied, depends on the tumor burden and also the radiologic pattern. And the test combined with the IO or land test, such as a TATIS or TATIS cell design, may prolong the progression-free survival. And for advanced HCC, IO, including the tetrabenazine or stride, is the standard of care. And currently, there is no solid evidence to support the optimal treatment as a second line after first line IO. But the different mechanism action and the tolerability are the key consideration for the sequencing choice. Thanks for your attention.
Thank you, Professor Huang, for your very excellent update. Right now, this talk open for discussion. Any question from the floor? Yes, please. Please indicate yourself.
Thank you, Professor, for your kind talk. I'm a medical oncologist from Taiwan, and I am curious about, there are recently two reports. One is Checkmate 90W, another one is Himalaya. They have shown the double immunotherapy and efficacy, but there has been a debate, or at least not a consensus, on the dosage, the interval, and the timing of CTLA-4 inhibitor. So what is your idea, or what is your proposal for such a treatment in conjunction with the PD-1? Thank you.
Yes, thank you. Thank you. It's a very interesting topic. Actually, the 90W, the data has not announced, so we should wait for the final report. But the study design for the stride regimen, just a single priming anti-CTLA-4. And for the EPNEMO, the 90W, they have 4 doses of CTLA-4. So for the safety concern, we will consider the single dose will be more safe. However, for the treatment efficacy, maybe multiple doses of the CTLA-4 may enhance the tumor response. So we still wait for the final report of the 90W to interpret the study design, which is better or which is worse.
Thank you. So for chapter B7, advanced stage hepatocellular carcinoma, which is systemic therapy, would you recommend?
Yeah. Thank you, Professor Liu. I think the chapter B is also a very big challenge for in clinical practice, because I think for a long-term, better long-term survival, good liver result is a key issue. For patients with BCLC B7, I think in our previous data show always, and also some other group all show the median overall survival for around 6 months only, even by the immunotherapy. So I think for such kind of patient, another way to improve the liver function is still very important, even by the systemic therapy alone.
Okay, thank you. So any additional question? Professor Omata?
Yes, may I? Thank you very much. In the hepatology, as a hepatologist, maybe BCLC is a standard. But if you go to other areas, like a USCC stage 1, 2, 3, 4. So in my hospital, I observed 16 years that regularly, including not just the hepatocellular carcinoma, but other organs, and USCC staging can stratify better than BCLC, because BCLC are complicated and there are so many factors you got to enroll. So for the future's sake, I think maybe we are very much specialized in this area. So maybe the intermediate state is fine, but how do you think about just employ other standard like other tumors?
Yeah, yes, I think I totally agree. So the BCLC not a very excellent guideline, and also some debate in Taiwan. So because I think the USCC also the T stage is can predict the outcome of most stage of HCC. So in my hospital, there's a dual system. You can use the TMM, also use the BCLC.
I try to see the RWD, to see the changes of the improvement of the outcomes. And then BCLC is just mixing things, So if you use the USCC criteria, it's clearly showing the recent improvement of the overall survival. So we are very much happy about that. So at the end point, maybe we better use the UICC criteria. How do you think?
Yeah.
No, sorry about it. Okay.
Yeah, agree.
Thank you very much. Yes.
Thank you.
Okay, I think the times are almost end, so Omada Sensei, we would like to give some closing.
Yes,
remarks.
this is just the beginning of the 5 days series of lectures, but it's wonderful. And then maybe we learn a lot. Actually, I may go to see the cherry blossoms. Thank you very much.
Thank you. So can we have a group photo? Omada Sensei? Yeah, with our speakers. Yeah.
photo.
Yeah.
Thank you very much to the lecturers and the moderators.